Assalamu alaikum wa rahmatullah. So we'll continue our review for basic anatomy, basic GI anatomy, and I left you at the pharynx. So we will start from there. So this is the pharynx. The pharynx is a funnel-shaped structure, and it's a passage for air and for food down to the trachea or to the esophagus. Now it has an anterior and posterior wall. The anterior wall, as you see, it's not continued. It's discontinued by the nasal cavity, the opening to the nasal cavity, and the opening to the oral cavity, and also the opening to the trachea. The posterior wall of the pharynx, we have the muscles. The pharynx is composed of two structures: fascia and muscles. The important thing to remember is the muscles of the pharynx. As you see here, we have three constrictor muscles: superior, middle, inferior constrictor, again superior, middle, inferior pharyngeal constrictor, and we have three longitudinal muscles. The first one is the first one is the stylopharyngeus muscle. The second one, this is the stylopharyngeus muscle. The second one is the palatoglossus muscle. This is the palatopharyngeus muscle, sorry. The palatopharyngeus muscle. The third one is not shown here. It's the salpingopharyngeus muscle. Salpingo means Eustachian tube, so it connects the Eustachian tube to the pharynx muscle. Not very important for you to remember. More important to remember the action of each of the muscles. Constrictor muscles, as you can imagine, the constrictor muscles, they will contract in the following direction. So they will propulse the food downward to the esophagus. So they act like as a sphincter to propulse the food downward. Longitudinal muscles, on the other hand, when they contract, they shorten the passage, they shorten the distance for the food or for any other thing in the pharynx to go downward. So they shorten the distance. All the muscles of the pharynx are supplied by one nerve, which is our big one giant nerve, the vagus nerve. So we have to remember this, that the vagus nerve supply everything in the pharynx: motor, sensory, etc. We have here an important point. The pharynx starts at the base of the skull. This is the base of the skull, the foramen magnum. So it starts from the base of the skull and it ends at the level of C6, lower border of C6, which is where the esophagus begins. We will talk about the esophagus in the next slides. So from the base of the skull to the lower border of C6 or cricoid cartilage. Now, at the start of the pharynx, as you see here, we have fascia. We don't have muscles here. We have fascia, a membrane actually called pharyngeo-basilar fascia. This is it, pharyngeo-basilar fascia. So the muscles, they are not attached to the base of the skull actually. They are attached to the median raphe, right here, and the base of the skull the muscles continue to the base of the skull as a membrane or as a fascia, pharyngeo-basilar fascia. Okay. Now you can notice here the openings. This is a posterior view for the pharynx. We've removed the posterior wall. This is the opening of the nasopharynx, and this is the opening of the oral cavity, and this is the epiglottis, and this is the where the larynx and then the trachea begins. This is the esophagus, should be here. We can see here two fossa, very clear. They're called the pyriform fossa. It's very important to remember the location of the fossa or the recess, and to remember their clinical importance, because pyriform fossa is the most common site for foreign body to stick. So if a child digested a coin or any foreign body, mostly it will, and it's stuck in the pharynx, mostly it will stick in the pyriform fossa. Now, what structures can be injured in this fossa, especially if the foreign body was like sharp, for example, like a knife or a small sharp object? We have deep to the mucous membrane of the pyriform fossa the recurrent laryngeal nerve. You know the recurrent laryngeal nerve because it supplies all the larynx muscle except one muscle, which is the cricothyroid muscle, and it's very important. Without if you have unilateral injury, you will be faced with dysphagia. So if you're faced with a question where a boy ingested some foreign body and he's having dysarthria, you will be thinking about object in the piriform fossa injuring the recurrent laryngeal nerve. Now, as you see here, posterior to the pharynx, we have a space called retropharyngeal space. This is it. We have more than one space, but I want you to remember this one especially, retropharyngeal space. This retropharyngeal space, as any space in the body, it can be infected, and an abscess can be formed here in the retropharyngeal space, or retropharyngeal abscess. This infection or this abscess can spread to another site according to the communication of this space. If they ask you where's the next space that can be affected by this abscess, it's the superior mediastinum. So retropharyngeal space connects with the superior mediastinum. At the level of C6, at the level of cricoid cartilage, the esophagus starts and the pharynx discontinue. So the esophagus and the trachea, they both start at the level of cricoid cartilage or C6. So the esophagus, there is no much thing to talk about here. The esophagus is a passage, just a passage for food until it reaches the stomach. And it has a lot of, it takes different orientation during its pathway to the stomach. It's not very important to know everything about the esophagus, but it's good to remember that the esophagus enters the abdomen at the level of T10. And I've already talked about the openings of the diaphragmatic opening, the three opening, and their exact location and the structures inside them. And it's very helpful to know them, so you can review the previous videos, the mediastinal videos, and you can get your information there. So as you see here, the vagus nerve travels with the esophagus inside the T10 opening. At the level of T11, the esophagus joins the stomach. Now you can notice the relation of the esophagus first to the trachea, so it's posterior to the trachea. Between the trachea and the esophagus, we have these beautiful nerves, which are called the recurrent laryngeal nerve. So the recurrent laryngeal nerves can be found, as I mentioned earlier, in the piriform fossa, and it's also between the trachea and the esophagus. After the esophagus, we have the stomach. The stomach is a dilated portion of the intestine. As we notice in this picture, the relation of the stomach to the different GI structures. So the liver covers part of the stomach, especially the left lobe of the liver. The stomach overlies the transverse colon, as you see here. Now, not shown in this picture, but you can imagine it. From the greater curvature of the stomach, we have what is called the greater omentum. Now, I will talk about the lesser and smaller omentum, lesser and greater omentum. They are very important. But for now, you can imagine that we have the greater omentum coming from the greater curvature and covering part of the transverse colon and the rectum, sigmoid colon, and many other structures, the small intestine, of course. The stomach occupies two parts of the abdomen, the epigastric part and the left hypochondriac part. Left hypochondriac and the epigastric. This is the parts of the stomach. As you see here, we have the fundus of the stomach, we have the body, which occupies the major part of the stomach, and we have the pylorus, which is defined by the angular incisori. The angular incisori is an imaginary line that divides the body from the pylorus. The pylorus is also subdivided to pyloric canal and pyloric antrum. Now, the fundus of the stomach usually contains gases, and this is important clinically, especially when you see imaging like the following. So when you want to identify the fundus of the stomach, you just look for the gas. So there's gas, there is the fundus of the stomach, and this is the diaphragm. Another point to talk about is the opening. We have two openings in the stomach, the cardial opening, which is the superior one, and the inferior one, which is the pyloric opening that connects the stomach to the duodenum. Very important to remember the blood supply of each GI structure. Very, very high yield. The first one is the esophagus. The one is the stomach. The stomach has a very rich blood supply, as you see in this picture, very clear. We will start by the lesser curvature. In the lesser curvature, we have two arteries. We have the left gastric artery and we have the right gastric artery. By the way, the celiac trunk, which gives the left gastric, I've reviewed its branches with the full details, so you can return to the major vessel videos to see the celiac trunk branches. So the left gastric artery takes origin directly from the celiac trunk, and it, as you see here, it covers the upper part of the lesser curvature. And it's important to remember the picture, the exact location of each artery. The right gastric artery, on the other hand, takes origin from the hepatic artery, from the proper hepatic artery mostly. Sometimes it takes its origin directly from the common hepatic artery, not shown in this picture. On the greater curvature, we have the gastroepiploic arteries. Now we have a left and we have a right gastroepiploic artery. The left gastroepiploic artery takes origin from the splenic artery. This is the splenic artery, and this is the left gastroepiploic artery. So directly from it, we have the left gastroepiploic. The right gastroepiploic, on the other hand, takes origin from the gastroduodenal artery. This is the gastroduodenal artery that takes origin from the common hepatic artery. Common hepatic from the celiac trunk, and then gastroduodenal. Gastroduodenal gives one of its branches is the right gastroepiploic that covers the inferior part of the greater curvature, as you see here. The final artery, and very important for you not to miss, is the short gastric artery. The short gastric artery, they cover the fundus of the stomach, as you see here, and they take their origin directly from the splenic artery also. So the splenic artery is very generous for the stomach. It gives the left gastroepiploic and it gives the short gastric artery. Another important thing to point out here is the peptic ulcer relation and the ulcer complication. Now we all know the peptic ulcer, a very common disease, and we all see it in the clinics and in rounds. You see this gastroduodenal artery and its relation, it's posterior to the first part of duodenum. We will talk about different parts of duodenum, but you have to remember that gastroduodenal is posterior to the first part of duodenum. So duodenum, as you know, is very common site for peptic ulcer, especially the proximal part, and especially H. pylori induced ulcer. So we have a general rule in surgery that is called posterior ulcers penetrate, anterior ulcers perforate. What does that mean? Posterior ulcers penetrate, it means that posterior ulcers tend to make penetration to the wall and it injures the surrounding structures. Anterior ulcers make perforations, and perforation in the abdomen, you know, they lead to a very serious and potentially lethal condition called peritonitis. So posterior ulcers, they injure the surrounding structures. Surrounding structure in this case, as I mentioned, gastroduodenal arteries. So from peptic ulcer, you can have, especially if it was posterior, on the posterior wall, you can have a very dangerous blood supply inside the abdomen because of the gastroduodenal artery relation. Now you can have bleeding from other sides according to the ulcer location. For example, if I told you that there is an ulcer on the upper part of the lesser curvature, and I told you that there is bleeding, so you should answer me that the bleeding is coming from the left gastric artery. If I told you that it was on the right, on the greater curvature lower part, it would be the right gastroepiploic, and so on. So understanding the blood supply of the stomach is very essential for you.